Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is approach to abnormal cervical cancer screening tests. We have already seen the test which are currently available for us to do the cervical cancer screening. In the last class on cervical cancer screening, we have seen this, and this is just a revision. Preferred test at present is primary HPV test. Whenever we say primary HPV test, primary terminology itself indicates that it is a stand-alone test. It is a test, only single test which is being done. Whereas if the second test is, which this is the preferred stand-alone test or primary HPV test. And whenever we say HPV test, it is always high risk HPV test. HPV test terminology is equivalent to the HPV test, which is detecting the high risk strains for development of cervical cancer. Second test is co-test. Co-test is where we are using the HPV DNA test along with cytology. Now both these are available only at high resource settings, and still there are so many centers or so many large parts of the country like India where the primary screening is still being done by cervical cytology, and so it is the sometimes it is the main screening test which is available, especially at the middle level resources. Now even cervical cytology also, if it is not available, then what health professional have in hand, it is VI, that is visual inspection after application of acetic acid, which is available at the low resource settings. Now whenever we get a abnormal report after doing any of these four screening tests, that is this primary HPV test, secondly co-test, third is cervical cytology, and the last is VI. Out of these, if any of the tests were as per the resources available, we do. And if the report comes abnormal, then there are so many questions which come to our mind, such as should every abnormal test indicates colposcopy and directed biopsy? What are the indications of colposcopy? What is the triaging for various scenarios? How to prevent unnecessary interventions? That is the main concern for us. What to do if colposcopy is not available, and when to go for screen and treat approach. So these are the questions which we will try to answer as we proceed with the today's class. And answer for all these questions, in my opinion, lies in following the evidence-based guidelines, which are fortunately ours is a fortunate generation where easily at a click we have the availability of so many guidelines with us, so that we can select the guideline which is appropriate for our scenario or appropriate for our resources and proceed with a proper patient management. Available guidelines for us in India, the most important available guideline for us is FOXI, Good Clinical Practice Recommendations 2018. We also should be aware of American Cancer Society 2020 guideline, as it is the latest one, which is showing us where the change in the guideline is going, where the change in the thinking process of those who are actively involved with the cervical cancer prevention, where the thought process is directed, that we understand. And we also have WHO 2021, which is available for all of us to go through it, read it, and implement whenever we find it appropriate. There are two approaches. First is called as screen and treat approach, where the decision to treat is based on one positive screening test only. This approach is acceptable, but what is preferred approach is the screen, triage and treat approach, where decision to treat is based on positive screening test plus positive second triage test, or a positive or a high risk, indicating a high risk for malignancy triage test. So it is at least the appearance of or presence of two positives that leads to the decision for treatment, and that is why it is a preferred approach as compared to the screen and treat approach. There are certain main differences which I have found between American Cancer Society 2020 guideline and WHO 2021 guideline for the screening of cervical cancer. First is, as per American Cancer Society, screening they have advocated to be started at 25 years, whereas WHO says that screening should be started at 30 years. ACS is advocating primary HPV test every 5 years, whereas WHO is advocating primary HPV test 5 to 10 years. Screening should be stopped as per ACS at the age of 65, provided previous series of tests are negative. Whereas as per WHO, we can stop screening after the age of 50 years. After 50 years, we should do two consecutive tests. That means if we are doing the HPV testing every 5 years, if we are doing cervical cytology, then every 3 years. And if these two tests are negative, then we can stop screening. That means if we are following cervical cytology by the age of 56, we have done at 53 and 56 two tests, and both at the 3-year interval, and both the tests cervical cytology are showing normal results, then we can stop at the age of 56. Whereas if we are following the HPV testing primary or co-test, then we have to repeat the test at 55 and 60, and we can stop at the age of 60. That is the meaning of this sentence. The main reason behind this WHO, what WHO has given is visual inspection after application of acetic acid or ablative treatments are not suitable after menopause. What is happening after menopause, as we all know, this is the reproductive life where this is the endocervical canal, this is the blue one is a transformation zone, and pink one is ectocervix. But after menopause, with the estrogen deficiency, there is so much of genital changes are there, hypoestrogenism is there, and there is a shift of transformation zone inside the endocervical canal, and that is the reason why it is WHO says that VIA and ablative treatments are not suitable after menopause, and that is why there is no need to keep on doing this test to the age of 65 years. As our main aim of screening is to catch the disease in precursor state as well as treat the disease in the pre-malignant state. For HIV positive women and immunocompromised women, the WHO says that screening should be started at 25, screen every 3 to 5 years if we are using the HPV test, screen every 3 years if the cervical cytology is being used, stop screening at 50 years after two consecutive negative tests. So because the stoppage of the screening is same for HIV positive as well as those who are HIV negative. This is a revision of Bethesda system for cervical cytology, where these are the various terminologies which are used while reporting the cervical smear for cytology. For squamous cell, the terminology which is used is NILM. NILM is negative for intraepithelial lesion or malignancy. Negative for intraepithelial lesion or malignancy. ASCUS and LSIL I have grouped together because the management in most of the guidelines is similar for these two. ASCUS is atypical squamous cells of undetermined significance. LSIL is low-grade squamous intraepithelial lesion. Whereas I have grouped these two together because the management for these two also is usually similar in all the guidelines. ACSH is atypical squamous cells where HSIL cannot be ruled out, and HSIL is high-grade squamous intraepithelial lesion. Significance even to ACSH as far as further treatment goes is same as for HSIL. SCC is squamous cell carcinoma. Which are used for glandular cells are AGC, that is atypical glandular cells. Where it is to specify whether atypical cells in bracket whether the atypical cells are endocervical, endometrial, and if these two cannot be differentiated, then not otherwise specific or NOS. AGCFN is atypical glandular cells favor neoplasia. AIS is endocervical adenomatous carcinoma in situ. Then sometimes we can get endometrial cells, and especially if there are endometrial cells in a woman with age more than 40 years, it should be reported in the cervical cytology if it is observed. Adenocarcinoma and others. So that is how the reporting will be done by using these terminologies. If whenever a cytologist is commenting about the glandular cell abnormality. Now, whenever we do the screening for cervical cancer, we can get abnormal test result as if we are using the primary HPV test, it can come as positive primary HPV test. If we are using co-test, then it will come positive, and there are three possibilities with the co-test. That is when we are using both. We are using HPV testing as well as cervical cytology. So either both can be positive, or only HPV can be positive, or only cytology might be positive. When we are using cervical cytology as a test for cervical cancer screening, then whenever it is not a NILM, that is negative for intraepithelial lesion or malignancy, it is considered as abnormal. And with the VIA, and presence of acetohyte area or areas is considered as abnormal. So what should be the next step whenever we are getting the abnormal report? If we get a positive primary HPV test, that is if it is abnormal, primary HPV test is abnormal and the age of the woman is more than 30 years, then preferred approach is screen, triage and treat. This is the preferred approach. So for that, for triaging, we need to do another test, second test. That second test shows high risk result or it is positive, then colposcopy and biopsy is indicated. If there is a low risk result or negative result, then we can repeat the HPV test after 1 year. So this is very, very important that every primary HPV positive test which is positive is not directly for colposcopy and biopsy. One should do the triaging and do another test. That test also shows high risk for development of cervical cancer. Then only we should be proceeding for colposcopy and biopsy is the main concept behind that. Patient is suppose not compliant, then the second approach is screen and treat. It is acceptable, but always remember that preferred approach is screen, triage and treat. So how to do the triaging? We can do triaging with a primary HPV test result showing being positive. Triaging can be done by using either HPV genotyping, cervical cytology or VIA. And remember that all these three have equal importance. There is nothing like genotyping is superior to cytology or VIA is inferior to these two, nothing like that, because one has to use according to whatever facilities are available. That is the main uh, concept behind that. And the studies have shown that end results are same, whatever is the method for triaging is used, the end result, that means the patient outcome is same. So if we are using HPV genotyping, then what is our main reason for doing genotyping is to know whether there is a presence of HPV 16 or 18. If it is present, that means it is a high risk factor for development of invasive cancer or CIN and invasive cancer. And so in that scenario, it is an indication to go for colposcopy and biopsy. Now understand that whole aim of triaging is to reduce the burden and to reduce the unnecessary colposcopies and biopsies. Now, if we are using cervical cytology, if it is NILM, that means it is there is no invasive intraepithelial, there is no intraepithelial cervical intraepithelial lesion or malignancy, then it is an indication to repeat HPV test after 1 year. Similarly, HPV genotyping is showing the presence of a strain which is non-16 or 18. It is an indication to repeat the HPV test after 1 year. I have used blue color for the low risk results, where it is an indication to repeat HPV test after 1 year and that shows positivity, then only to go for colposcopy and biopsy. If we are using VIA and there are no acid-white areas, again it is an indication to repeat primary HPV test after 1 year. On the other hand, whenever there is a high risk report such as presence of HPV 16, 18 or cytology is showing anything above or equal to ASCUS is either ASCUS, LSIL, or there is a ACS-H, that is abnormal squamous cells or where HSIL cannot be ruled out, or HSIL. So any of these four will be an indication to proceed with colposcopy and biopsy. And if there are acid-white areas, it is with the VIA, it will be an indication to proceed with colposcopy and directed biopsy. If a patient is not compliant and you know that when you are doing a triaging and waiting for the results, you might lose the patient. Then in that scenario only, it is acceptable to proceed with screen and treat. That means you can proceed with colposcopy and directed biopsy with a single primary HPV test being positive. Now with the co-test, there are three scenarios I have already said. Both tests are positive, HPV and cytology, then no doubt that is an indication to proceed with the colposcopy and biopsy and further evaluate and treat the patient. Second scenario, HPV is positive but cytology is negative. Then in that case, as HPV is positive, we do the genotyping. If it is non-16, 18, repeat co-test after 1 year. Or there is another important option is HPV positive but cytology negative, we can directly go for repeat co-testing after 1 year. Now remember that it is a cervical intraepithelial neoplasia takes years to convert to invasive, and that too it converts to invasive only in few cases. Not all patients of cervical intraepithelial neoplasia will always go for a invasive disease. Not all patients with HPV positive will go for CIN. That is also another important concept which you need to understand, that HPV positivity does not equate with CIN or invasive cancer. HPV positive 90% resolve spontaneously without any treatment in next 2 years, and that is the reason, this is the rationale behind this guideline, that whenever HPV positive cytology negative, we can repeat co-test after 1 year, or if facilities are available, then we can go for genotyping, and if it is non-16, 18, repeat co-test after 1 year, 16 or 18, then go for colposcopy and biopsy. If HPV test is negative and cytology is positive, then for ASCUS and LSIL, we repeat co-test after 1 year, as these are low risk lesions where cytological abnormalities, whereas if it is abnormal squamous cell where HSIL cannot be ruled out, or it is HSIL These are high risk, and whenever H is there, what I remember, whenever H is there in the cytology report, it is a direct indication for colposcopy and biopsy. So if you understand the rationale, then it becomes easier to even without memorizing, think about the next step in the flowcharts related to these tests. Now, if we are banking on the cervical cytology as a primary cervical cancer screening test, as we do at so many centers still in India, and it is, I think, in the if we see majority of the women in India who are getting screened for cervical cancer, they are being subjected to cervical cytology, whereas there is a small percentage who can afford and who where the HPV test is available. Now, in that case, as I said, H is there, colposcopy and biopsy with endocervical assessment. So ACH, HSIL, it is easy to remember, always for colposcopy biopsy. Now, there is some difference between ASCUS and LSIL. LSIL is slightly a serious abnormality as compared to ASCUS. So ASCUS is the only report where there is an option of repeating cytology after 1 year, or one can go for HPV test. Whereas LSI, either go for HPV test or go for colposcopy and biopsy. But if patient is not compliant and you are not very sure that whether she will come for the biopsy report or not, she might not be able to come. Such a scenario with LSI, we can go with the VIA screen and treat approach. It is for non-compliant. Whereas with ASCUS, similar scenario, patient not compliant, then colposcopy and biopsy can be done. Or if colposcopy is not available, we can go with VIA screen and treat approach. This is another way of demonstrating diagrammatically the same whatever we have discussed in the last slide, that if it is H, it is for colposcopy biopsy with endocervical assessment. Endocervical curettage should also be done if it is ACH or HSI. If it is ASCUS, then in that case we can repeat cytology after 1 year. If it is ASI, we can go for colposcopy, and if facilities are available, patient can afford, for both these situations we can go for HPV test. But whenever there is a non-compliance, then for ASCUS, we can directly go for colposcopy, or for VIA screen and treat, and LSIL also we can go for screen and treat. So VIA is mainly you see where the acetobyte area is there and take care of it in the same sitting by doing the ablation. That is screen and treat approach. If patient is less than 30 years and there is abnormal cytology report, then again H is there, colposcopy with or VIA if colposcopy is not available, and directed biopsy. Whereas ASCUS and LSIL, we can repeat the cytology on yearly basis, and we can repeat it for 2 more years and see if all the reports are showing abnormality, then only to go for colposcopy or VIA directed biopsy. But if again here non-compliant patient, we can go for directly for colposcopy directed biopsy or VIA directed biopsy. So colposcopy is not available. That means you don't do anything. It's not like that. In that case, you do go for visual inspection after application of acetic acid and take a biopsy from acetobyte areas and evaluate the patient and treat the patient as per the biopsy report. If there are abnormal glandular cells showing abnormal endometrial cells, it is an indication for endocervical endometrial curettage. On the other hand, if there are abnormal glandular cells which are endocervical or not otherwise specific, or abnormal glandular cell favoring neoplasia, or even endocervical adenocarcinoma in C2 like picture is there, or cytology report is there, for all these situations what is indicated is colposcopy with or without biopsy. That means if ascitovite area is there, then we should take biopsy, endocervical as well as endometrial curettage. Last is VIA, visual inspection after application of acetic acid, where positive VIA is an indication if facilities are available to do the colposcopy and take a colposcopy directed biopsy. That is proper screen, triage and treat approach. But if this colposcope is not available, then in the same sitting we can proceed with screen and treat approach, where either we can proceed with cryocauterization or electrocauterization. So cryocauterization is better as compared to electrocauterization results wise, but whatever facilities are there, we can do this. This is called as ablative therapy or ablation. Now there are certain criteria which are very important, which guide us whether to or help us to select a patient who is for screen and treat. First is this acetovite lesion should be completely on ectocervix. It should be occupying less than 2/4 of the ectocervix, that means like less than 50% of the ectocervix. There should not be any extension of this acetovite area in the vagina, towards the vagina or in the endocervical canal. There should not be any other features suggestive of invasive cancer, such as there should not be postcoital bleeding or postmenopausal bleeding. Visible growth should not be there. It should not be bleeding on touch, whatever area is there, acetovite area, and there should not be any irregular contour of the transformation zone. If all these criteria are getting fulfilled, then we can proceed with screen and treat approach in patients who are non-compliant, where single visit you do VIA and same visit you do ablation. It is mainly for low resource settings. Take home message is screen triage treat is preferred approach. Screen treat approach is acceptable for non-compliant patients. Advantage of triaging is it reduces unnecessary colposcopies and biopsies. HPV testing, O-test, cytology and VIA all have equal weightage as far as triaging goes. Any ACH or HSIL is always for colposcopy and directed biopsy. VIA and biopsy can be done if colposcopy is not available. Always remember the criteria for screen and treat approach. Don't get bogged down or confused, especially for postgraduate students. This is the important take-home message. Don't get bogged down or confused with multiple flowcharts. If you see any guideline, you will see so many flowcharts and you will be lost in that. Rather, understand the rationale behind flowcharts to reduce the need to mug up the topic. Write down the flowcharts yourself 2 to 3 times so that the concepts become clearer for you. Thank you so much.